it's funny me asking you this because I'm on IR right now, but I'll ask you since you obviously know as well as I do. So people are probably wondering, like, we've kind of laid it out, the landscape. What does like a typical day on the IR rotation look like for a resident? What
Yeah, I think we can tag team this one. But as you work up patients in the morning or the night before. You chart on them in the morning. You see the patients if they're inpatient. You
Mhm.
consent them if they haven't been already. Then you prepare the list. You prepare all your images. You present them to the team. You round with the team, and then things start moving. Yeah, the day begins, and you're scrubbing into procedures. You're logging cases. You're dictating reports. You're following up with family. You're following up with providers, and then you're working up consults throughout the day and just doing a modified version of everything I just said on repeat.
Mhm.
And that's how your day runs. And you run through like 6 or 7 or 8 or 9 or 10 different cases of all sorts of variety, and before you know it, the day's over and you've had a wonderful day of fun.
That's right. Even if you get out at 7:30.
Exactly, exactly.
No, I think you pretty much hit it. I think like you said, there's a lot. It's a very which is cool about it. It can be hectic, but is cool as there's a variety of things you're doing. You're seeing patients in the hospital, you're doing outpatient, procedures on patients in the hospital, patients that are coming in from the outpatient as well. You're seeing consults from in the hospital as well, which is you're essentially, I wouldn't say a primary service because you're not like the primary team, but you have your kind of primary scheduled procedures for that day. And then obviously you can have a lot of consults and add-ons and things like that. And I'll add that a consult, is not just looking at the imaging and kind of chart checking. Like you go up to the floor, just like, a surgical, it's functions, I would say very much like a surgical service. Like you said, it's, you go up on the floor and you see the patient yourself and examine them, and whichever and what type of exam you do is kind of relevant to the procedure. If someone calls you for like a biliary drain because they have elevated liver enzymes, you're going to go up and obviously examine their abdomen, see if they're jaundiced. Labs, you'll review their liver enzymes, their bilirubin, things like that. So it's a lot of clinical evaluation. It's not quite to the extent as a medicine doctor, but because you're kind of more focused on the problem at hand or the problem you're being asked about. But
Mhm.
a lot of clinical evaluation for sure.
Yeah, yeah, definitely.
um yeah, and I feel like the rest of it kind of runs like you say. You run through the patients, and then you kind of, usually that's it. I think it depends like what level you're at. Like at our level, we're doing a lot more of the consenting, and the lower
Yeah.
junior resident level, consenting patients, seeing consults, coordinating with teams, the prime ordering teams and stuff like that. And then the fellow, I think you're at that stage, you're still doing some of those things, but I feel like at that stage it's more kind of honing your skills, as an operator.
Exactly. Yeah. No, totally.
So I guess we've talked about what the rotation looks like. So I guess people, a lot of med students wonder about the schedule, like what type of hours do we work, especially on IR. I think we should probably we should probably address diagnostic too as well, because I think it's important to point out, and you can elaborate on this, is that we, a lot of our training, we're still trained as diagnostic. Even yourself as an integrated IR resident, you're still trained as a diagnostic radiologist as well. um, and I guess like what is our call schedule? Because like IR is certainly on call all the time.
Yeah. So, I mean, once again, I think it's very program specific. I think the diagnostic years, and it's relative to what you're comparing it to. If you're comparing the diagnostic years to like a general surgery residency, I mean, I think objectively we could probably say that the diagnostic radiology residency requires less hours in the hospital. That said, you know, as we're both going through our first year of radiology residency, we can say that certainly there's more free time than we may have had during our intern year. But I think the expectation is also that we use that time to really study our craft and to really learn this new language that we have to communicate through our, evaluation of images. And so I think the first year is structured wherever you go for radiology to accommodate that learning curve that's very difficult. And I think the second year, you're picking up more call, and then your third year you're picking up more call, and then come fourth year or your R4 year, you're doing these mini fellowships, a variety of electives, and really jumping into whatever specialty that you've chosen to pursue, as many now do pursue subspecialty training. That said, I think for the subspecialty of IR that we'll be pursuing, I think it's variable on the institution size and the number of trainees available, and the sort of maybe even the practice model that the trainee is at. And so, I've heard anywhere between the worst I've heard is Q2 call. I think Q3 or Q4 is more standard, and I've also heard Q5. But it's a function of how many hospitals you're covering, how many trainees are available, and what sort of services you'll be providing. But that said, it's certainly not a walk in the park, and I think the hours that you're working as a trainee in IR, or at least during your IR specific rotations, are probably easily 11, 12-hour days. And you can speak to this right now. I mean, you probably woke up at 5 and you came back at 7. It's not it's not a walk in the park by any means. But I will say that during my intern year, when I was on interventional radiology as compared to maybe a general medicine month, the time I spent was like, it was almost inconsequential, in that like the day kind of flew by because I was enjoying it so much. And I think that's sort of a really good sign of you doing something you really love, and it just being a natural part of your day. To kind of talk about that a little bit further, the training doesn't necessarily reflect your future life. Like, there are a lot of different practices. Most trainees will be in academic practices, which makes sense, and they can be more demanding, definitely. And I think when you go out into practice, or at least from what I've heard, there's a whole lot of variety in the practice type you can choose from or be hired to, and that you can, if you want to, you can work that 7 to 4, 8 to 5 job if you'd like, or you can be extremely prolific and work even more than you would at a major academic center, or and so it really, I think the training will be hard. Hopefully it'll prepare you. It should prepare you, and then whatever you want to do afterwards is really your lifestyle. It can be highly variable. It's really up to what you're looking for and what you want.
Yeah, I think that's an excellent point. I mean, versus a field like, say, like neurosurgery, I've had a neurosurgeon on the podcast. We talk about this, that, you're it's pretty hard to have a limited hour, much more limited hours attending job as a neurosurgeon. It's just the nature of the job. Or like interventional cardiology, where you're on call all the time, and, you're getting called in to do, STEMIs and things like that. It's just much more difficult versus IR. I think, you have much more control over, like you said, your hours, your schedule, how much you're on call, things like that. Because you could decide, you could, there's some IRs that just don't do certain procedures that would be more, like, for example, some IRs don't do, or a number of them don't do any peripheral artery disease work, or something like that, that may require, more follow-up, more, more clinical workup, things like that. Requiring patients to be rounded on in the hospital and things like that. Some IRs, they do exclusively outpatient, or maybe, vast majority of their practice is outpatient work. So they're almost never going to the hospital.
Mhm.
Versus, some of the attendees we work with, do very high level, complex cases.
Right.
So I think that's another nice thing, I guess, is the variety of cases you can do as an attending, and then off of that, the variety of lifestyles you can have.
I think what we're conventionally told is that there's a trade-off. When you're in an academic center, you can do more complex cases, and then when you go to like a community practice, you end up doing more bread and butter cases. I don't know that that's necessarily true anymore. And I think we both listened to different IR lectures that kind of focus on this very fact that there's a lot of private practices these days that do high end, high level IR without necessarily the academic setting. And so
Mhm.
there's a lot of mixing and matching of practice types, cases, like very diverse to very common. And so it's I'm kind of curious to see where it goes by the time we're looking at that same job market. Um, but I think at the very least right now, I think you can. I would hope you could find what you want